All right, so now we're gonna change topics here and head back to the heart to talk about different concepts of the heart. And the first one is what we call cardiac output. We like to know, we like to be able to calculate someone's cardiac output. And what that means is how much blood is leaving the left ventricle and going into the aorta per minute. So how much volume of blood. And on average, it's about 5 liters in an adult per minute that leaves the left ventricle. So when you think cardiac output, think of left ventricle, not the rest of the heart. What's leaving the left ventricle? And this is decided by, well, how much volume is leaving per stroke. That's the stroke volume. So per contraction of the left ventricle, how much blood is being pumped out. And then the heart rate multiplied by the heart rate. And that gives you your cardiac output per minute. Because if in one beat you're pumping, say, 50 milliliters, and you have 60 beats per minute, well, it's 50 milliliters per beat, and it's 60 beats, so it's 50 times 60. So the concept is basically how much volume is leaving the heart per minute. So what factors can affect stroke volume and cardiac output? Well, because the heart wants to be able to increase or decrease cardiac output based on what you're doing. If you decide right now to climb up one of the hills in Salt Lake, around Salt Lake City, you're going to need a lot more cardiac output. If you decide just to relax or fall asleep, the heart doesn't need a high cardiac output. So it wants to regulate up or down as needed. So let's start with these concepts below. So preload. So the preload is basically how much blood did the ventricle get filled with that's now going to be pumped out for the next beat. How much was it loaded with from the atrium? Okay, it's just it's just the filling of the ventricle at the end of diastole. So, for example, if for whatever reason you don't fill the ventricle from the atrium because you're low on blood, say, well, your preload is going to be very low, and so you won't have much to pump out. So preload, it'll make more sense as we go along, but preload is a concept that tells you how much did the ventricle fill during diastole. Okay, what about the strength of contractility? So this is where how hard did that muscle, the myocardium, contract during that pump to get the blood out. So the sympathetic system can increase contractility of the heart. There's drugs that we use, such as epinephrine, norepinephrine, intravenously, to increase contractility of the heart. So if you contract harder, your stroke volume is going to be higher, and so will your cardiac output. What about afterload? So afterload is basically how much pressure am I having to pump against? So in general, think of afterload as your blood pressure, because your blood pressure is what your heart has to pump, is what the left ventricle has to pump against. So if you have a very high afterload, if your blood pressure is 200, the poor left ventricle is going to have to reach a pressure of 200 before the aortic valve opens and allows blood out. So the afterload is telling you how hard is it going to be? How much pressure am I going to have to generate to get to pump into the aorta? So that will also decide stroke volume. Because if you have an extremely high afterload, you need to generate an incredibly high pressure to even start getting some stroke volume out. Okay, so these are all things that can affect stroke volume. The other one is heart rate. Well, heart rate's just a number of how many beats per minute, and that can be affected by exercise level, by fear, anxiety, by hypotension. Your heart's going to increase its heart rate if you're low on pressure. So that's all controlled by the sympathetic and the parasympathetic system. So stroke volume is the volume per minute, and heart rate is how many beats per minute. And this will decide the number of liters or whatever volume measurement you're using, the number of liters per minute. So let's talk about blood pressure. So what's generating the blood pressure? Well, it's the pumping of the heart. So it's how much blood is being moved into the arteries, the aorta, or the arterial system, let's say. So that's your cardiac output. And how much is leaving the arteries, and that is dependent on your peripheral vascular resistance. So if you have very low resistance in all your arteries and arterioles, well, the blood's just going to keep flowing through them because the resistance is low, and your pressure will be low because it's not maintaining a high pressure if the resistance is low, because the blood just keeps on going. So if you have a high vascular resistance, you're likely going, so you're vasoconstricted, you're likely going to have a higher pressure, because it's the vascular resistance is from the little tiny capillaries and arterioles that are stopping the blood from leaving the arterial system. So that's going to maintain arterial pressure, and they're influenced. The tone or the resistance in the vessels are controlled by the sympathetic system and also the renin-angiotensin system. So angiotensin 2, that will keep the pressure up in the system if both of those are activated. So what does the heart do, or what does the system do to maintain its blood pressure? Well, it has baroreceptors, typically in the aorta and in the carotid arteries, that monitor the blood pressure, and then it sends signals to the autonomic nervous system. So if it's sensing a low blood pressure, it's going to activate the autonomic nervous system, namely the sympathetic system, to increase cardiac output, either through heart rate or contractility of the heart, and also to vasoconstrict all those arterioles around the body, so that the blood pressure is maintained in the arterial system. If the blood pressure is extremely high, the signal can decrease. If the signal decreases from the baroreceptors, the arterioles will vasodilate, they'll open a bit, and the blood pressure, the heart rate will go down, and the contractility will reduce, and this will reduce overall blood pressure. So there's a constant adjustment of cardiac output and peripheral vascular resistance. Okay, so we spoke about stroke volume a bit, the bottom one. So we spoke about the blood coming into the ventricles. That's the preload. Okay, so the ventricles have been loaded with blood. And what's going to determine the stroke volume on top of the preload? Well, how hard is the myocardium, the heart, going to contract? What's the overall volume status of the person? Like, are they dehydrated? Are they overhydrated? And these are all, so volume and hydration is controlled by a whole bunch of different systems that we'll get to. So the renin-angiotensin system, it controls volume and blood pressure, ADH, aldosterone. Don't worry, we're going to get to all these systems. The overall concept is the body wants to maintain blood pressure and overall normal volume. So don't memorize those now because we're going to come to them individually. Let's look at this slide on the left. Let's say your blood pressure right at the top is low. So arterial blood pressure, low. That's going to send a signal from the baroreceptors that are, as you can see here, they're showing the carotids. So they're going to sense this low pressure, and they're going to do everything they can to increase the blood pressure. Because without arterial blood pressure, the brain will not get food, and that is what the whole system is about. The brain needs oxygen, and it needs glucose. And in order to get that, it needs blood pressure. So if the pressure is low, there's going to be a signal sent to the sympathetic system to vasoconstrict all these different arterial beds all over the body, whether it's the legs, the intestines, the kidneys, to vasoconstrict. Let's keep the blood pressure up. What else is going to happen? There's going to be sympathetic activity sent to the heart to say the blood pressure is low. I want you to increase heart rate, and I want you to increase contractility of the heart to try and get this blood pressure back up. Okay, what else is going to happen? The kidneys are going to sense the fact that the blood pressure is low, and they're going to excrete renin. Renin is finally, I hope you've done this system. If not, just listen to it briefly. You don't have to memorize it. Renin is going to activate angiotensinogen. That's going to turn into angiotensin 1, and then finally angiotensin 2. That is an extremely powerful vasoconstrictor. So that's also going to vasoconstrict all these arteries around the body. Same idea, to maintain blood pressure. And it's also going to secrete aldosterone, which goes to the kidneys to reabsorb salt and reabsorb water. Again, to maintain blood pressure and to maintain blood volume. So all these systems are in place to make sure that blood pressure is maintained for the brain and for the heart. Okay, so this next slide, we're going to talk about blood pressure. And on one of the earlier slides, we used the term systole and diastole. And systole is where we're talking about the ventricles contracting, in particular the left ventricle. So left ventricular systole is going to generate your systolic blood pressure. When the left ventricle relaxes is when you're going to generate your diastolic blood pressure. So blood pressure is the pressure of the circulating blood on the inner arterial walls, the pressure that the blood exerts on the inner arterial walls. That's what blood pressure is defined as. Systolic blood pressure is the arterial blood pressure during a heart contraction or during systole. Diastolic blood pressure is the blood pressure during relaxation of the heart, diastole. And it's going to be lower because the heart's not beating and the blood is flowing through all the little arterioles that are going to go to the capillaries and then the venous side. So your diastolic blood pressure is going to be lower because you're allowing some of the blood to flow through the arterioles, so it's leaking through the whole vascular system. I shouldn't say leaking, but it's flowing through the vascular system. So the diastolic blood pressure is the pressure that we measure while the heart is resting before the next beat. Now remember, the blood pressure always refers to arterial blood pressure. It has nothing to do with the venous side. It's the systemic arterial blood pressure. A normal blood pressure is anything, so we have listed here 120 over 80. 120 being the systolic, 80 being the diastolic. So any pressure that's less than 140 systolic and less than 90 diastolic is considered normal. So 140 over 90 is the cutoff between normal and hypertensive. So the device, the cuff that you put around someone's arm to measure blood pressure, and then the measuring of the blood pressure with the entire device is called a sphygmomanometer. Okay, long term, that's just the device that we use to measure blood pressure. And remember that blood pressure, as we get older, what happens? The arteries get stiffer and stiffer. They're not as flexible anymore during heart contractions, where the arteries are able to flex open a bit more and then and stretch. They don't do that as we get older. They get calcified a bit. So when the heart pumps and the arteries can't stretch, the systolic blood pressure tends to go up very quickly because there's no give in the system. So old people tend to get systolic hypertension. Okay, so factors influencing blood pressure. This is a busy slide. I wouldn't get overly excited about it. We'll just keep it. Let's make a bit of sense of it. Now, I apologize if there's some background noise once in a while, because I'm often in a hospital when I'm doing this, so I can't always control the background noise, but I'm trying to keep it to a minimum. Okay, so really, we're looking at blood pressure. And I've said before, we care about blood pressure because blood pressure is what allows for perfusion of the brain, the heart, and other organs. So the body is going to keep the blood pressure in very tight limits. Okay, it doesn't want it to get too low and it doesn't want it to get too high. Now, blood pressure is decided by cardiac output, how much the heart is putting out in terms of volume, and systemic vascular resistance, how vasoconstricted, how narrow the arterioles and capillaries are in the system, in the arterial system, to slow down the speed of blood flow through them. So if they're very vasoconstricted, the blood flow is going to be low, and you'll likely be able to maintain a higher pressure. If they're wide open, vasodilated, the pressures is going to go down. So let's look at the top box here, cardiac. Well, anything that increases heart rate, contractility, conduction of electricity in the heart, that's going to increase cardiac output, because we've already said that cardiac output is stroke volume times heart rate. So that one makes sense. The lower one, renal fluid volume control. Well, the renin-angiotensin-aldosterone system is going to maintain blood volume. So if you maintain a normal blood volume, you'll be able to fill your ventricles, the preload, which will then allow for proper cardiac output. So let's use an example of someone who's severely dehydrated. They haven't had anything to drink in days. They're lost in the desert. So what's happening is their blood volume is diminished, their pressure is low, their blood pressure is low. Well, why is that happening? Well, the whole system is low on volume, so the return of blood to the heart is low, to the right side of the heart, from the veins. which then causes less flow to the left side of the heart, so a reduced preload to the left ventricle. And if you have reduced preload or reduced preload in the left ventricle, it can't pump out as much, so your stroke volume is reduced. If your stroke volume is reduced, then your blood pressure is going to be low. So a low, I mean, it makes intuitive sense. If you have low volume in the whole system, then you're likely going to have low blood pressure. What about vascular resistance? Well, so your sympathetic system is going to vasoconstrict the vascular system. So it's going to increase vascular resistance. So in particular, alpha-1 agonists, they're going to vasoconstrict. So something like norepinephrine is going to vasoconstrict, or phenylephrine. So it's going to raise your blood pressure by vasoconstricting tightly and keeping the blood pressure elevated by stopping the flow through all the little capillaries. What about vasodilation? Well, if you have a medication that vasodilates the system, such as, let's use nitroglycerin. If you haven't heard of that medication yet, don't worry, we're going to get to it. It's a vasodilator. So it's going to cause the arteries and the veins to vasodilate, and that's going to reduce systemic vascular resistance. The bottom box is just mentioning so vasoconstrictors we've mentioned, such as norepinephrine. Angiotensin II is a powerful vasoconstrictor in the system, so that'll raise blood pressure by having its effect on the vascular resistance. And then local regulation, these are all little chemicals in each little vascular bed, whether it's the little arterioles going to the kidney or the spleen. Each vascular bed has local regulators, chemicals that can alter the size of the arterioles in that area. And these are things like endothelin, nitric oxide, that you may have, NO, that you may have heard of. These are local. So you can see there's a lot of regulation of blood pressure from this slide. Okay, so let's just talk about these three concepts a bit more: preload, contractility, and afterload. And when we're talking about preload and afterload, we're really talking about the ventricles, not so much the atrium. So the preload is how much blood is coming into the ventricles, the right or the left, during diastole, which is the state where the ventricles are relaxing. And we want to know sometimes the preload because that's the volume of blood coming into the ventricles that's getting ready to be contracted out of the ventricles and moved forward. Okay? So if you have a very low preload state, such as dehydration, well, you're going to have less blood coming to the right side of the heart, so less venous return. The right ventricle isn't going to fill well with blood, and then the right ventricle isn't going to be able to pump very much blood into the pulmonary artery because there's a low preload state. Let's look at the term afterload. So afterload really refers to what is the pressure that the ventricles are having to pump against. So if I asked you, what's the pressure that the left ventricle has to pump against? Well, it's the blood pressure, because it has to overcome the pressure in the aorta, which is your blood pressure. Okay? What is the afterload that the right ventricle has to pump against? Well, it's the pulmonary artery pressure. So afterload is just telling us what is the pressure that these ventricles have to pump against. And the right ventricle, remember, is a low pressure state. So a pressure in the pulmonary artery of 10 or 15 millimeters of mercury is quite normal. On the other side, the left ventricle is pumping against blood pressures of, say, 100 or 120. Okay, so very different afterloads from the left side of the heart compared to the right side of the heart. What about contractility? So contractility is really referring to how hard is the myocardium, the heart muscle, contracting. Okay, so some of it is determined by how much blood filled the ventricle, whether we're talking about left or right. How was the preload? Because when you fill the ventricle, it stretches the heart muscle in the chamber and gets it ready for a good contraction. So preload is determining the contractility of the heart, of the ventricle. What else is determining contractility? Well, what about the sympathetic nervous system, right? So the sympathetic nervous system not only can accelerate the heart rate, it can speed up the heart rate, but it also increases contractility of the myocardium itself. Okay, so if you think of contractility as, okay, how powerfully is this ventricle contracting? That is the contractility, and that's determined by the preload, but also determined by how much sympathetic nervous system stimulation is impacting the heart. So you're going to hear terms in pharmacology and pathophysiology such as inotropy and chronotropy. So anything that's a positive chronotrope is referring to it's increasing the heart rate. Anything that's a negative chronotrope is reducing the heart rate. Anything that is a positive inotrope is increasing contractility of the heart. And an example of that would be epinephrine. That would increase contractility of the heart. And a negative inotrope is some kind of a medication that will reduce contractility of the heart. Okay, I hope that makes sense. Okay, so blood pressure matters. So why do we care about blood pressure? Why does it matter so much? As long as it's at a certain level to feed the brain, who cares? Well, we care because over time, and having done many studies, we know that chronic high blood pressure damages the arteries. So the inner walls of the arteries living under high blood pressure damages the arteries. It also risks a leak, a hemorrhage. So if we look at the diagram on the right, we can get strokes. We can get strokes because the artery has broken or like hemorrhaged. We can get bleeds in the eye, hemorrhages in the retina, causing blindness. We can get heart attacks, and we'll get to why hypertension or high blood pressure causes high heart attacks. But you can imagine the poor heart having to pump against very high blood pressures. This will lead to heart failure as the heart finds it more and more difficult to pump against a high blood pressure. You can get a condition called heart failure. That's not the same as heart arrest or cardiac arrest. It just means that the heart is getting weaker and weaker and weaker. The blood pressure, the chronic high blood pressure also damages the kidneys because they're not capable of existing year in, year out with these high pressures in the arterioles and in the arteries that are flowing to them. So if you look at almost any organ, whether it's the brain, the heart, the kidneys, or just the arteries in general, if they're having to live under chronic hypertension, high blood pressure in them all the time, it actually damages the lining, the endothelial lining of the artery, and it can lead to what's called atherosclerosis, which is plaque formation within the arteries, or they can hemorrhage, they can break open because of the high blood pressure. The equation below is let's review it. So the cardiac output is just the volume leaving the heart of blood. The resistance of the arterial vessels, if it's a high resistance, not much blood is going to get through, so it's going to maintain a higher blood pressure. So cardiac output times vascular resistance is giving us an approximation of blood pressure. And remember, blood pressure is really the afterload of what the left ventricle is pumping against. So to put it in slightly simpler terms, sometimes I'll try to use analogies. So you have a container, which is basically all your arteries, and you have a volume of blood. And how much volume, which is cardiac output, are you stuffing, pumping into this container? If you're trying to put a lot of volume of blood into the container and the container isn't allowing blood to flow through it, so a high resistance, your blood pressure is going to be high. If your container has a lot of flow through it, a low vascular resistance, then your blood pressure is going to be low. Okay, so receptors. So the receptors monitor and alter blood pressure. So we've mentioned baroreceptors and how they send signals back to the heart in terms of the autonomic nervous system, sympathetic and parasympathetic, to say speed up, slow down, and that's constantly to adjust the blood pressure. Baro is pressure, so baroreceptors monitoring blood pressure. Chemoreceptors also exist in blood vessels, and they're constantly monitoring the chemicals in the blood, the pH, the oxygen level, the CO2 level, and they can alter blood pressure, and also they can alter other factors so that the pH, oxygen, and other gases in the blood are maintained at a normal level. So remember, the body always wants to stay in homeostasis. It can't live with huge variations in oxygen and CO2 and pH. It needs homeostasis, and it has all these receptors to try and achieve that. So when we're thinking of blood pressure and maintaining blood pressure, there's a number of systems. So the first system is the autonomic nervous system, the sympathetic and parasympathetic, and how they can constantly adjust the heart rate, the contractility, and also the vascular resistance in the arterioles. So the sympathetic system will vasoconstrict the arterioles to maintain a blood pressure. So this is another system, the renin-angiotensin-aldosterone system. And this system is also activated in the setting of a low blood pressure. And the system will, in the end, produce angiotensin II. And angiotensin II, remember, the reason why this system was activated was low blood pressure. So now, at the end of this system, we have angiotensin II that's going to vasoconstrict the arterioles, the small arteries, and also stimulate the adrenal gland to release aldosterone. And aldosterone is going to reabsorb water and salt to maintain blood volume. So this whole system is to, again, bring the blood pressure up. So there's multiple systems that you need to keep in mind that are keeping the blood pressure up in case it starts to drop, say from hypotension from hemorrhaging. You have a gastrointestinal bleed, you're losing a lot of blood. These systems, whether it's the autonomic nervous system, the renin-angiotensin-aldosterone system, are activated to keep the blood pressure up. And there's another system we'll come to. So this slide is really a repetition. You can skip it if you want, but it's just a nice reminder of how the renin-angiotensin-aldosterone system is working. And remember, the trigger for this whole system is decreased kidney perfusion. The kidneys are sensing low blood pressure in their vessels, which leads to renin secretion. Renin causes angiotensinogen, which is produced in the liver. Remember, most proteins are produced in the liver, to be converted to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin 1 converting enzyme. Okay? And angiotensin 2 does two things. It goes to the adrenal gland through the bloodstream and stimulates aldosterone secretion from the adrenal gland. What does aldosterone do? It goes to the kidney and it stimulates reabsorption of sodium into the bloodstream, which then will also cause reabsorption of water into the bloodstream. In that process, it secretes potassium into the nephron. Okay, so it's reabsorbing sodium and getting rid of potassium in the nephron, and of course then into the urine. The other activation that it does when I'm talking about angiotensin 2 is it's a very powerful vasoconstrictor of the arterial system. And when you vasoconstrict the arterial system, you're going to raise blood pressure, okay? Because you're stopping the blood flow from continually getting through the arterioles. And that's exactly what the system wants to do. It wants to raise blood pressure, okay? And it does that with aldosterone and vasoconstriction by angiotensin 2. Okay, so what triggers the renin-angiotensin-aldosterone system? Well, hopefully by now, decreased kidney perfusion will be your answer, because the kidneys are sensing a low blood pressure state, whether it's from a hemorrhage or from dehydration or anything that's causing a reduced blood perfusion to them, and that will cause renin to be secreted into the bloodstream. Okay. Remember, angiotensinogen is made in the liver. It's converted by renin to angiotensin 1. And then finally, angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. Okay. So I hope that is clear. And remember, this system is really important for maintaining blood pressure. Just like ADH is used to reabsorb fluid from the nephrons, and that's another system to maintain blood pressure. And then, of course, the sympathetic nervous system is also very involved in maintaining blood pressure if it senses that it's too low. Okay, so think of those systems as doing everything they can to maintain proper blood pressure. Okay, so in this question, what is the end result of the renin-angiotensin-aldosterone system? Increasing urine output, and that's not going to be the end result because you're reabsorbing sodium and reabsorbing water from aldosterone. So you're going to have decreased urine output, right? So, and that makes sense because if your blood pressure is low, your body's going to do everything it can to reabsorb fluid and not let it leave as urine. Increases blood pressure. Well, that's the answer, right? It's increasing plasma volume, thereby increasing blood pressure. Decreases cardiac output. No, that's not at all what this system is for. And vasodilation, not at all. It's actually vasoconstriction by angiotensin II.